just realised that I put this upside down. My rectum's up the top, and it should be down the bottom. So I'll flip that later. Hey, let's talk about Invictus. The oral board review form of Invictus is called Encore, but it's actually going to come out first, which is funny. And that should be coming out in the next month or so. And then the written has turned out to be much bigger than we thought. We were having to bring more people into the studio. But it's coming along really nicely with lots of questions, lots of written summaries. We've got a deal with Roche, and it's going to be pretty spectacular. And then it's going to be an ongoing discussion thing that we're going to do that maybe some of you are going to want to do for the rest of your life, because I believe that ER docs should be doing continuous board review. So I'm sorry it will be a little bit delayed. I thought by the end of the summer, but we're going to have to keep working at this for a few more months. So here he is, Sean Nordt, who is board certified ER doc, who's also a pharmacologist, who also is a toxicologist, who's also got degrees in pain and palliative care. He is amazing. And he's also a super nice guy. So this is the quality of the lectures that you're going to be getting on Invictus. Nobody knows this stuff better than Sean. All right, go.
Antidepressants. Now, this is a really important group of medications to talk about, because unfortunately, many of our patients do struggle with depression, and they're going to be on these agents, and then they have an increased risk for potential self-harm. We're going to start with the cyclic antidepressants. Here's a question. A 35-year-old ingested 50 to 60 tablets of amitriptyline. Patients obtunded and intubated. They develop a wide complex tachycardia and then resolve with sodium bicarbonate intravenous push. What is the mechanism of the cardiotoxicity causing this QRS widening? Is it fast sodium channel blockade? Is it muscarinic 2 receptor blockade? Is it L-type channel, calcium channel blockade? Or is it histamine 1 receptor blockade? And the answer is fast sodium channel blockade. Cyclic antidepressants used to be very widely used. Now, they were very effective, but they had lots of adverse effects, but also very high mortality risk if someone took too much, or let's say an intentional ingestion. The way that they work in large part is they inhibit catecholamine reuptake, and that includes norepinephrine and serotonin, and the serotonin increases the mood, okay? The norepinephrine, if you've heard, when someone started on a antidepressant, particularly the cyclic antidepressants, you usually don't give them more than 1 week supply. And that's because they get sort of this boost of energy. And the thought was, hey, they were so depressed before that they wouldn't even try to kill themselves. But now, particularly with that increase in norepinephrine and the serotonin, now they have the energy to actually harm themselves. So if you are in the position to prescribe this, no more than 7 days until they're stabilized on it. Here's a bunch of different ones that are here. So the original ones are the tertiary ones, like amitriptyline. Nortriptyline is known as secondary. That is the metabolite of amitriptyline. Imipramine tertiary. Dicipramine is the metabolite of imipramine. And then you can see doxepine, all these other ones. The tertiaries are much more sedating. They have a lot more antihistaminic and anticholinergic effects than the other ones. But the nortriptyline and dicipramine absolutely do too. The anticholinergic effect is from that muscarinic blockade. This is very distressing to patients because they'd have dry mouth, blurred vision, urinary retention, constipation, all these other things. They can get somnolent, and that's from the histamine 1 blockade. And then the thing that we worry about with poisoning is not only that fast sodium channel blockade causing the QRS widening, but it also can cause hypotension because of an alpha adrenergic blocker. So if someone was just even on this chronically, they can get orthostatic hypotension, but this is something that we'll see in acute poisonings. So what are the toxicities that we see? Antimuscarinic, right? They can get confused, all the other things. Alpha adrenergic blockade, that's the hypotension. Sodium channel blockade, that's the QRS widening, the ventricular dysrhythmias. And then the GABA antagonism is what causes the seizures. So how do they present? And if you've never seen one of these, they're pretty scary because the patient comes in, they're pretty awake, they might have some anticholinergic signs or symptoms, and it's easy to focus on that, but that is the least of our worries. It's really the cardiotoxicity that we're going to worry about. But what happens is they're lethargic, they're obtunded, but then they have a seizure, and they just go from like being wide awake or pretty awake, and then they slip over and they have a seizure. When they seize, the pH drops, and that makes the binding to the cardiac myocytes much better, and then they widen out their QRS and go into VT. And so you don't want them to have a seizure. So when I used to see these quite a bit, I used to actually prophylactically treat them with diazepam or lorazepam to minimize the chance of them having a seizure. And I always have boxes of sodium bicarbonate right at the bedside. Now, QTC prolongation can happen, particularly with chronic use, but almost never with any of these medications you have to worry about with acute poisoning. So the sodium channel blockade findings, what do we see on an ECG? You see sinus tachycardia very often. That's from the anticholinergic effects, but you see a rightward axis, you see a prominent R wave in AVR, and then you get the QRS widening. I always worry about a relative sinus bradycardia with QRS widening and let's say QT prolongation, because this does set them up for dysrhythmias. Torsade, this would be the rare case that you would see if they have QT prolongation, but with QRS prolongation, I do worry about that causing VT or VFib. What are some common medications? So we talked about cyclic antidepressants. Diphenhydramine can do it. Propranolol is a beta blocker, but actually has sodium channel blockade effects. So you can see QRS widening, you can actually see seizures. Quinidine and quinine, those are sodium channel blockers 1A types, as is procainamide. Cocaine, so cocaine is a local anesthetic as well as a pathomimetic, carbamazepine, and then local anesthetics. So how are you going to treat any of these? I always say, if you have anybody who has widened QRS and you think it's from some sort of ingestion or toxin, just treat with bicarb and worry about it later. So you're going to prevent the seizures, ideally, with benzos, phenobarbital. Phenytoin and other anticonvulsants do not work for drug-induced or medication-induced seizures. If they are hypotensive, the sodium bicarbonate actually works pretty well for that. What it does is it increases the pH, it changes that binding at the cardiac myocytes, and it also provides volume. But QRS widening, you'll hear different toxicologists use different numbers, generally greater than 100 or 120. And then, of course, if they're in a ventricular dysrhythmia, just give it. Alpha agonists, you want to use direct-acting agonists such as norepinephrine or phenylephrine. Dopamine, at least, there's some concern that it might worsen it. We really don't use dopamine anymore, so it's almost a moot point. And, of course, if they're hypotensive, just give them IV crystalloid. Intubate them early, particularly if they're starting to get obtunded, and physostigmine is not recommended. It will reverse the anticholinergic effects, but it also is associated with increased mortality and increased ventricular dysrhythmias. SSRIs and SNRIs, or selective serotonin reuptake inhibitors, or SSRIs, serotonin norepinephrine reuptake inhibitors. These are two classes of antidepressants. They're widely used with distinct mechanism of action. Okay, so how do SSRIs work? Well, it's in the name, right? It's like they say, what does it say on the tin? It does what it says it's on the tin. So it inhibits the reuptake of serotonin, or 5-HT, and this is at the serotonin transporter. And this increases serotonin at the synaptic cleft. And then there's all those agents. So fluoxetine, sertraline, paroxetine, those are the earlier ones. And kind of not much happened in poisoning. They would get maybe a little tachycardia. They get a little somnolent. But then citalopram and escitalopram, they can actually get sick. And then SNRIs, much more worrisome with acute poisonings. They inhibit both the reuptake of serotonin, but also norepinephrine, okay? And this is venlafaxine, desvenlafaxine, and duloxetine. What are some of the common adverse effects of SSRIs? They have, so remember ondansetron. Ondansetron is a 5-HT3 or serotonin blocker. So if you have excess serotonin, you get GI disturbances like nausea, vomiting, and diarrhea. Sexual dysfunction is a common one. Patients can gain weight. All right. Some of the serious effects is increased risk of bleeding. So if you were to do an lumbar puncture and someone is on an SSRI, you want to at least pause and say, do you really need to do this? Now, and the guidelines don't say that you can't do it, but just know that there's a lot of data to suggest or support that SSRIs do increase the risk of bleeding. And then, of course, serotonin syndrome can happen. Okay, SNRIs, some of the stuff is just common stuff like dizziness, dry mouth, sweating, sexual dysfunction. But this is the one that is much more dangerous in acute poisoning. So you can see hypertension, but you see seizures much more commonly. Serotonin syndrome can be seen, as well as hepatotoxicity chronically. Here's a question. A 22-year-old presents after a Bupropion overdose. Patient has a seizure, witness en route. Which additional complication is likely? Bradycardia, QTC prolongation, wide QRS and ventricular dysrhythmia, or respiratory depression? The thing we worry most about, in addition to seizures, is a wide QRS and ventricular dysrhythmia with Bupropion. Bupropion, it's used for so many things. Of course, major depressive disorder, but it's also used for seasonal affective disorder, smoking cessation, weight loss. And this is a norepinephrine and dopamine reuptake inhibitor. And this is much more serious than the SSRIs by far in poisonings. So with an acute ingestion, we can see seizures, and actually you can see seizures with just people being a little bit super therapeutic. You can see clonus, myoclonus, hyperreflexia, hypotension, decrease in sodium, but the thing that we also worry about is QRS widening, and this is not from sodium channel blockade. This is from cardiac gap junction. It blocks the intracellular communication. So you can use bicarbonate. Very often it doesn't work. So that's just something to know about. Intravenous lipid emulsion we'll talk about mostly when we talk about local anesthetic systemic toxicity, but it has been used in cardiac arrest for Bupropion poisoning. Monoamine oxidase inhibitors, an old medication but very testable. So monoamine oxidase breaks down catecholamines. It comes in two major types, monoamine oxidase A and monoamine oxidase B. A is predominantly A for alimentary. A for alimentary, so it's mostly in the GI tract. So what happens if you inhibit monoamine oxidase type A and you eat tyramine foods, which are biogenically active and usually get broken down in the gut, you can get clinical response to this. Monoamine oxidase B, B for brain, this is why they're used for Parkinson's disease. The traditional monoamine oxidase inhibitors like phenelzine, phenylcyprine, and bind irreversibly. Now these were super effective for treatment refractory depression, but they're just so risk of toxicity, particularly if someone takes an acute poison, they're rarely used. Of course, the monoamine oxidase B are used for Parkinson's. So let's just talk about common adverse effects of these, particularly the original types, the non-selective ones. So orthostatic hypotension, weight gain, sexual dysfunction, insomnia. But if someone takes a large amount, they can get a hypertensive crisis. Or if they have, remember I mentioned about those tyramine foods, and that's the aged cheeses, red wine, because the tyramine now is biogenic and it can cause all these effects. And then serotonin syndrome. This is really a class of medication that we worry particularly about serotonin syndrome. In acute ingestions, as I mentioned, you can get hypertension, hyperthermia, seizures and coma, and often that hypertension can be followed by hypotension. So there's a lot of drug-drug interactions. Now we call it serotonin toxicity because serotonin toxicity or serotonin syndrome is very predictable. It's from an excess amount of serotonin. This is not idiosyncratic. So if you have somebody who's on multiple serotonergic agents such as meperidine, sympathomimetics, dextromethorphan, linezolid, cyclic antidepressants, SSRIs, SNRIs, lithium, there's many others, but that can increase the risk of serotonin toxicity or serotonin syndrome. So monoamine oxidase inhibitors, if someone takes an acute ingestion, you're going to see tachycardia, hypertension may be delayed, followed by hypotension. Hyperthermia can be seen. They can have seizures. It's basically supportive care. If they're hyperthermic, cool them. If they're hypertensive, we generally just kind of wait because you usually don't have to treat it because of that hypotension. You can give them IV fluids. If they're not responsive, which they may not be, a direct-acting vasopressor such as norepinephrine or phenylephrine. Serotonin toxicity or serotonin syndrome, neuroleptic malignant syndrome or NMS, and malignant hyperthermia. Clinically, these are somewhat overlapping and can be hard to distinguish if they're all in your differential, but we're going to go through them. Neuromuscular findings, so serotonin toxicity is hyperreflexia and clonus. They can have rigidity, but it's usually mild. NMS is where you can't move them, and they have decreased reflexes. And malignant hyperthermia you should not see in the emergency department. This is generally in the OR or operating theater when someone is on an inhaled anesthetic, and this is when they have generalized muscle rigidity, particularly masseter muscle rigidity. So let's go into these, and I'll provide this table to you, but let's go into these in detail because they're very testable. So serotonin syndrome or serotonin toxicity, remember, this is excess serotonin. And this is usually from multiple medications. And I have all of them there. SSRIs, MRI, monoamine oxidase inhibitors, SNRIs, whatever it is. This is excess serotonin, and the onset is rapid within minutes to hours. This is not over days. Okay, neuroleptic malignant syndrome. This should not be seen in the emergency department. If you're seeing this in the emergency department routinely, I guarantee you're probably seeing serotonin toxicity. This actually takes 1 to 3 days. It's psychiatrists that see this. This is generally seen with dopamine antagonists such as haloperidol, spiridone, droperidol. And what happens is it's over 1 to 3 days, and it's generally when the dose is being escalated. Okay? And then malignant hyperthermia, this should only be seen in the OR or operating theater. And this is inhaled volatile anesthetics, although it is described with succinylcholine as well. This is a mutation in the ryanodine receptor, and this is genetic. Okay? And what this is, it's causing that the calcium to bind, and people cannot move. And this is life-threatening. So this happens within minutes too. So how are you going to treat these? Well, of course, any of these immediately stop the agent, okay? But if you find that they have hyperreflexia and clonus, start thinking about serotonin syndrome. Most toxicologists, including me, say if they don't have clonus, they pretty much don't have serotonin syndrome. If they have lead pipe rigidity, if this happened in the emergency department with bradyreflexia and they're on their appropriate medications for it, think about that, and then malignant hyperthermia, okay? But the treatment is going to be, again, discontinue everything. Supportive care, now they can all cause hyperthermia, so you want to actively cool them. Benzos, you can't go wrong, particularly for serotonin syndrome and neuroleptic malignant syndrome. You can give it for malignant hyperthermia, but the only thing that's going to work for that is dantrolene. What dantrolene is working at the sarcolemma, because this is a calcium problem. For serotonin syndrome, it's just supportive care. Cool them, you might have to intubate them. Ciprofloxacin is a serotonin antagonist. The problem is it's only oral, and it takes hours to work. Little downside to giving it, but mostly supportive care. Neuroleptic malignant syndrome, it really is just supportive care to benzos. Now, dantrolene, some people will use, it's controversial. If somebody was on bromocriptine, let's say, and they abruptly discontinued it, you want to give them a bromocriptine or a amantadine. But again, malignant hyperthermia, you have to give dantrolene. That's the only thing that's going to work. Serotonin 5-HT3 receptor antagonists. We use these every day, all day, particularly on Danstron. Of course, there's Granisetron too. They work by blocking 5-HT3 or serotonin in the gastrointestinal tract and the central nervous system at the chemoreceptor trigger zone. They have very minimal adverse effects. So if patients are on these, sometimes they'll have headaches, sometimes constipation. Now, QT prolongation is that you hear all the time. Now, this medication is used all day, every day, and you really don't see torsade commonly, but it has been described particularly when very high doses were used. But it is very testable for standardized exams. Dopamine receptor antagonists, particularly D2 receptors, this is metoclopramide, prochlorperazine, promethazine, droperidol. They block dopamine or D2 receptors in the chemoreceptor trigger zone. Now, it is used for a lot of things, nausea, but they're actually very good, at least in my opinion, but probably yours as well, for migraine-associated headache and nausea. Gastroparesis, particularly metoclopramide, because it is a prokinetic agent. They have a lot more adverse effects than other antiemetics, particularly the extrapyramidal effects. Now, dystonia, and you've all seen this, but this is very distressing to the patients, right? They'll come in with torticollis or have these other things. You'll give them an anticholinergic such as diphenhydramine. Akaesthesia is that feeling where they might pull out the IV, or you're far out in the car park or you need a parking lot because they just ran away. That is idiosyncratic. That is not improved with diphenhydramine. Generally, it's just reassurance benzodiazepines for that. They can cause sedation. QT prolongation, really you don't have to worry as much as other medications. However, droperidol and haloperidol, it is a boxed warning, so very testable. So just be careful. If someone had a prolonged QTC, maybe try trimethylbenzamide or Tigan. That has really no effect on the QTC interval. And then tardive dyskinesia, this is generally seen with prolonged use.